So we're going to take a look at the clinical practice guideline from the Journal of Orthopedic Sports Physical Therapy regarding heel pain and plantar fasciitis. So the big things that I chose this is because it's one of the few that's had an initial CPG come out and then a follow-up with revisions associated with it to show kind of progression of evidence-based practice within the context of physical therapy for heel pain and plantar fasciitis. So the big thing we're going to do first is take a quick look at clinical practice guidelines, just a little refresher, and then we'll get into kind of what it says and how we progress. Those are the big things. And then how that actually affects you in your clinical practice, whether it's PT, AT, whatever that is. So a lot of times the clinical practice guidelines are viewed in two kind of opposing views, right? Kind of polar opposites. And so those two kind of different positions I think are summarized pretty well here. I don't know why it turns upside down like that, but so you didn't see it at the end, but at the end of it, I'm not sure why I cut off. Zoolander gets shocked, right? So he questions what's being told to him in the same way a lot of times we question clinical practice guidelines or protocol. Like, well, what about my clinical expertise, my clinical judgment? And that's not really what they're designed. They're not designed to mandate to you what to be done. Sometimes insurance or other things for the PT world will view it that way, but they're guidelines from which you kind of adapt to the person in front of you. And if you can view them from that context, they've got a lot of meaningful data because it's so hard to keep up with all the evidence. But on the flip side of that, some people kind of view them a little bit more like those, like mystic crystal liberations. So, right, so that's what we kind of view them as, like, this panacea, like, give me a protocol, give me a guideline, let me be told what to do, and that takes away from our clinical expertise. So really, the truth lies somewhere in the middle. And I think, if we look at the context of what they were for, initially for three things they were designed to do. One, manage costs, improve care, and then reduce variation. And it's not just to reduce variation, because all of our patients are unique, right? So there's going to be variety. It's the unwarranted variation. So if Michael's seeing the same patient as me, and we're in two different localities, and they present fundamentally similarly, we should be using similar treatments, right? Now, if there's differences between our patients, then we have to adjust based on that. But there's too much unwarranted variation, which affects the cost, which also affects the care. And if we look at them again from the goal of that context, that is a very noble goal to have, and that's what they're intended to do, and it fits very nicely with the AAA. This is what most healthcare systems are trying to do right now, which again is to reduce cost, right? So manage costs. We're trying to improve health, so more people getting better, reducing that, improving care, and then also improving quality, and we can do that through reducing unwarranted variation. And really, at the end of the day, just like Lexis is the pursuit of perfection, it's not the achievement of perfection, right? We're not going to achieve probably ever the ideal treatment for any particular condition because of the nuances of the human body. But we can identify what we should be looking at first and foremost as our primary options, and then adapt based on response or other clinical presentations. And just like Lexis is engineering amazing, that's exactly what all of us in this room are doing it. We're just doing it with the human body instead of a vehicle, right? Which is actually more impressive. So, just looking at kind of where we come, right? 2008 to 2014, there's a really big push on evidence-based practice. And I just kind of use this slide. There's a lot of numbers on it, but it just kind of shows a couple big things, right? So we've got the levels of evidence, which go from 1 to 5. So your high-quality RCT is diagnostic and prospective. Your level 2 is, again, lesser quality or only 1. Maybe a high-level study. Your level 3 is looking at case control series. Level 4 is a case study. And level 5 is going to be your expert opinion, which again doesn't mean that it's not valuable, it's just you have to view it in the proper context, the proper lens. And then the grades, again, A is pretty much all level 1 studies. Level B, or an overwhelming number of level 1 studies. 2 is at least 1 level 1. C is going to be weak evidence. And so, strong, moderate, weak, and then D is conflicting. E is theoretical, foundational, so animal, cadaver studies, those kinds of things. And then F is going to be, again, the recommendations of the clinical practice guidelines based on their expert opinion and their expertise in the field that may not be as supported by the actual can see, right, level 1, we go from 3 studies in 2008 to 18 in 2014. Level, grade A evidence, we got 2, it goes up to 5. And you can just see the overwhelming numbers just fly from just that small levels. 2008 is looking from about 1994. It really says anything before 2007, but the references go back to 1994. And then in 2014, it's filling the gap. We go from 60 studies to 100 studies in that short window, and really kind of progressing at a very rapid pace. So this is just in terms of diagnosis. If somebody comes in with complaints of posterior heel pain, these are the things that are recommended to be looking at, right? So your classic palpation, looking for pain, reproduction, and this is usually after them coming in with either an increase in weight-bearing activity. You're going to be looking for limited dorsiflexion in active or passive. You may also be looking, not so much in this population, but in a non-athletic, you'll be looking at BMI too. In an athletic population, that part of the process doesn't really apply, because it's muscle mass, not adipose. So the tarsal tunnel test, you're looking at negative, right? You want to rule out radiating kind of symptoms, numbness, tingling, those types of things. And then you're also looking at your windlass test in both weight-bearing and non-weight. 2014 actually recommends the foot posture index, not the longitudinal arch angle, but just from a clinical perspective, what I find is kind of, you have to find that balance, and that's an example where I use the balance. The foot posture index is 6 additional tests, basically, or assessments, I should say, not so much tests. Whereas the longitudinal arch angle is just 1, but neither one of them have a really great body of literature to support them. The big thing is abnormal too, right? Both a high arch, right? So a cavus can be at a high risk for plantar fasciitis, but so can a pronated position. So it's really more you're looking for abnormalities in that position. It's not just one or the other. And real quick, you can see we were in 2008, we had a B recommendation, and still, in 2014, no changes there. In outcomes, you notice it goes from A to A, but the big thing to point out here is in 2008, it was the foot and ankle ability measure was the one that was most highly recommended in our kind of context in the rehabilitation world, because it had been validated in particular in a physical therapy environment. But it also mentioned the foot health status questionnaire, and a couple other ones as decent outcome measures. In 2014, there's 4 different ones, including a computer-adapted lower extremity functional scale. And again, that doesn't mean those are the only ones that are out there, but those were the ones that have the most research to support them. Activity limitations are just, clinical best practice clinical guidelines. So first, when you walk, how long after you walk, how long of inactivity, how long of standing if it's a prolonged weight-bearing activity, just your basic things that you're going to find in your evaluation. That's carried forward pretty well. And then your physical impairments are, kind of variations of those same types of things. And it wasn't even really assessed in 2008 to kind of see, well, what kind of actual physical impairments should we be looking at? And really what it's talking about too is that recent increase in weight-bearing activity. Again, that's regardless if it's athletic or non-athletic populations, right? So maybe when you're starting a running program for your runners, you're coming out of the off-season on in-season training, you're increasing those weight-bearing activities, and so that's when you're increasing the load through those structures, and you're most at risk for injuring those structures. So there's a lot on this slide, obviously, right? But I tried to kind of color code a little bit to kind of show, well, what has kind of got the highest recommendations for it. And you'll notice most of it is going to be kind of the hands-on type stuff, or less and less on the passive modalities. One of the big things that's most supported actually is night splints if you can get somebody to sleep in. It used to be just if it was chronic and not responding, but now they're starting to recommend you may want to consider it earlier in the process. The other part of that, taping is a good way to assess if they may be a good candidate for orthotic devices, right? If they respond well to taping, that may be another reason to be looking at, should we be getting them an orthotic device? And again, prefabricated, custom, doesn't matter. It's more just getting something supporting that foot, and you're getting an improved outcome there too. Stretching and manual therapy. Manual therapy, big jump there, right? We went from E in 2008 to saying, hey, caliper, remote, some other things might be good ideas, to now we're saying, and it's actually there's still a long ways to go, even with an A grade, because it's mostly soft tissue mobilization of the gastroc and soleus complex is what was found, but it's still recommended to be looking at your, because dorsiflexion is limited, mobilizations of the talocrural joint as well as other joints across the ankle, maybe even some soft tissue work in the plantar fascia itself. But there's still, manual is such a big term, and that we've got to look at not just at the plantar fascia, but also the ankle and other structures. So there's still emerging body of evidence that's going to happen there. Big things, electrotherapy. Iontophoresis went from a B grade, recommended in 2008, and now they've basically done studies and compared it to manual or other modalities, and it's not as effective, right? Comparative analysis. So maybe it was good against placebo or control, but when you comparatively grade it against manual stretching, taping, orthosis, it doesn't provide the relief And that's still, you can still use your clinical judgment, especially for the athletes, right? The acute period, trying to get some pain management. It's not saying that you can't do it, but it just doesn't have that level of evidence to support it. And it does have some conflicting evidence regarding if you're not doing at least some of these things. So if you're doing IONTO and not doing manual stretching and other kinds of things, that's where you really have to question what you're doing if you're choosing something that's not as well supported. The other ones, low-level lasers new, photophoresis, ultrasound, are all new. They got like 1 or 2 studies that kind of say, yeah, there might be some benefit, but they tend to not be comparative analysis, right? So they get better, but we know that if you treat somebody to get better, typically at least a little bit. And that's what happened with ultrasound and its progression, right? And we saw ultrasound is working, and then we started comparing it to sham ultrasound, and they just took, and the same kind of thing. They got better, and we realized that ultrasound's not really recommended. So for low-level photophoresis, they kind of say, yeah, maybe you can do it, maybe you can't. Ultrasound, they're saying we can't recommend that you do ultrasound. It doesn't look like it does anything for the patients. And then as we get to the other things that are going to continue to come up in the future, weight loss counseling for our non-athletic populations, not so much for your athletes. And then strengthening, right? I would think that strengthening in this day and age, we all probably do it as part of your rehab for plantar fasciitis and really any lower extremity injury. And yet, what's the evidence? It wasn't even reviewed in 2008 in terms of what you should be doing. And in 2014, which is the literature December 2012 and earlier, there's very little stuff that's out there, right? This is the recommendations of the clinical practice guidelines staff as picked by the Journal of Orthopedic Sports Physical Therapy, and it's their opinions in lieu of evidence. Dry needling is not that far off either. It's, again, it's the sexy thing that, a lot of people do. Unfortunately, in California, not at least physical therapists are not able to do it right now. That can always change, but again, it's sexy, it's interesting clinically, anecdotally, we see a lot of benefits. There is some research coming out, but it's still very early in the process in terms of its true value in that regard. And then, it's kind of on the fence about the shockwave and corticosteroid, not really in favor of them as a primary intervention for the management of the condition. So I just like to use this slide at towards the end here too to review again. We talked about clinical practice guidelines, but we should also be remembering what evidence-based practice is too. And it's not just clinical expertise, it's not just patient values, it's not just what the research literature says. They don't exist as separate pillars, and you can't just choose one or the other. They're interwoven into each other. It's a spectrum, it's a melting pot in terms of how those all interact. And so you can't just say, well, the evidence says this, but I just don't feel like following the evidence. I'm going to do this because I think it works. No, your clinical expertise and patient values really factor in, both with respect to the research, but especially when there's a break in the research, or there's something different about your patient, and you have to adjust it based on their values and your expertise. So what's missing? What do we need to be thinking about going forward? The big things are, again, this is only covering the literature through December 2012, and of course, if it was published by December 2012, that means it was done, probably a year or more prior to that, getting it published. So there's still a big gap in what's currently being done, what people are finding with clinical practice, anecdotal evidence, and what will be published in the near future. Again, strengthening, a big thing, we all do it, but where's the evidence for it? It's lacking, So there's a ton of opportunities here to grow the literature and gait training. How many of us think about plantar fasciitis, how people are loading as they go through their running, their cutting, or other kinds of things that could be affecting the load that's being transmitted through the plantar fascia, and yet again, not really analyzed. It's not published literature associated with those things. And then can we apply our principles of treatment into principles of, principles of treatment into injury prevention? I think that's where we're looking towards in the future, right? If we can prevent the athlete from having these kinds of injuries in the first place, then that's a much bigger value proposition than just treating. You're always going to have some injuries. You can't prevent them all. But if we can kind of incorporate and work some of these principles in and see if it has an effect with regards to prevention, then that's kind of the pinnacle, I think, of what we look for. The more we prevent, the more athletes stay on the field, the less lost time, coaches are happier with us, the team hopefully is happier as well and doing better as a result of that. And the new modalities, right? We're always researching new things. That's the shockwave therapy to some degree, dry needling to some degree, and there's always going to be, you guys at Stanford here are doing tons of research on new and emerging technologies, and any of those things could, start to shape additional treatment, prevention, and assessment strategies for the diagnosis and management of plantar fasciitis. So that really speaks to, we don't know what we don't know. And I kind of use this slide to kind of say it's Red Hot Chili Peppers or Song Snow, but it's the more I see, the less I know. Because and it fits really nicely with this Dunning-Kruger effect also, which talks about as when you first start, as an example, as an athletic trainer or physical therapist, I know for me personally, I felt really good. Like my first clinical rotation in school, I was like, oh yeah, I got this, this isn't so hard. And everything was black and white. And then you go along school and then you start practicing and things are like, I'm not quite as sure about this as what I once was. And you notice even the experts, right? Their confidence level never gets back to where they were as a new practitioner or a new whatever field they are, because there are so many things that we don't know. You don't know that until you really start getting out there and seeing all the different facets, which is the nice thing about the program that we're doing, because we see stuff at Cincinnati, at Stanford, at Wisconsin, and then we have our own personal practices and biases that can shape that. But other than that, that's pretty much kind of where we come to, where we're going with the clinical practice guidelines for heel pain. What we're looking at. Are there any questions that people have?
Do you know if any of the clinical practice guidelines or research they looked at proximal aspects of the hip and the knee, how that affected it, or is it just?
Yeah. So the strengthening one actually did. So the overwhelming body throughout the clinical practice guideline is just specific to localized to the ankle, maybe the calf complex, right? So the soft tissue most of those areas. But the strengthening aspect is starting to look at that. So the one study that it actually cites in there talks about looking at hip external rotation as reducing as positively impacting the mechanics at the foot level. And so, but that's theoretical foundational evidence really. But it supports the idea that hey, if I have better hip control, then it's going to affect the foot and vice versa. You can also make the argument for a stable core, all those kinds of things. And theoretically, foundational evidence, I would say it definitely makes sense in terms of interventionally and its effect on the patient. That's what we don't have clear-cut answers on that. That's probably where you're looking more at your clinical experience and when you see your patients get better, like, hey, I added hip exercises, work on the core, and all of a sudden, I done all this other stuff, and then I added these elements, and boom, I noticed a big difference. And you have to keep that in the back of your head. And then maybe that's the next research topic. I don't know. So, other questions?
Thanks, Chris.